People First Radio is a program about people, the society in which we live, and issues related to health and wellness.
Welcome to People First Radio. I'm Joe Pugh. Dr. Shawn Kelly is calling attention to youth and the opioid crisis. Kelly co-authored an editorial on the subject for the Canadian Medical Association Journal. In it, he said that early onset initiation and escalation of opioid use among youth is being overlooked. He says survey data suggests more youth are using opioids than in years past, but substance use disorder programs for youth remain scarce, fragmented, and often privately funded, with waitlists that are months long. The Ottawa-based pediatrician says that the problem runs deeper than the toxic drug supply, and he called for changes to Canada's public health system to remove out-of-pocket costs for families seeking care for youth using opioids. I spoke with Dr. Shawn Kelly.
My name's Shawn Kelly. I'm a pediatrician by training who's also done a fellowship in adolescent addiction medicine. And so I split my time here in Ottawa between treating some general pediatrics concerns and treating youth with mostly substance use disorders.
And you have co-written this editorial all about youth and the opioid crisis. Maybe to start with, can you help put this issue into perspective? What do we know about, say, how many youth are using opioids, and maybe what does that number mean in context?
Okay, so we know that lots of people are using opioids and lots of people are dying from opioid use. And there was a sort of a peak that was happening. It was about 22 Canadians per day were dying of an opioid overdose at its peak. It's down around 19 right now, which is still way too many, but does represent a slight relenting from the absolute peak of the crisis that we were in. However, 19 a day is still a crisis. And what we are seeing now is that we're seeing increasing numbers of youth using opioids. And what we have is some excellent data that comes from the Ontario Drug Use and Student Health Survey. And this is a survey that's done every few years. And it gives us a really robust look into what sort of substances are happening in high schools at the time. And it sort of divides it up by age. And there's some pretty scary data that emerged from the last iteration of this study, which showed that there was a nearly doubling to about 21.8% of youth who reported using prescription opioids in a non-prescription way, so like to get high, essentially, in high schools in Ontario. And this other scary part of that data was that it actually skewed younger, and the kids who were sort of in grades 7 to 9 were more likely to report having used opioids in this way than the older kids in grades 10, 11, and 12. And so it's pretty alarming, and it goes along with what we're seeing clinically, and when I say what we're seeing clinically, I belong to a loose network of other people who do similar work, and there are a few child and adolescent psychiatrists, and there's a few adolescent addiction medicine specialists like myself, and then there's a few people who are adolescent medicine providers. And we're all seeing a very similar and frightening picture, and which is that there's been a bit of a culture change. And this culture change is pretty frightening. So things like this Ontario Drug Use Survey help us see what's being used. And there's a little bit of variability that happens. And it's almost like the seasons, there's a little bit more cocaine use for a while, or cannabis use goes up and then it comes back down. And there's small variability in things. But typically, opioids were on the other side of a protective imaginary line. And it wasn't a common part of the high school drug use experience. It happened, and I've certainly treated people with opioid use disorder for my whole career in addiction medicine, as young as 13 years old, and that remains the case. But what's happened is now that opioid use has come from the fringes and taken a few steps towards the mainstream, and so it's become this common refrain of people using dillies at parties or getting dillies from their buddy. And dillies is the youth vernacular for Dilaudid, which is hydromorphone. And that is really the opioid of choice that is being used amongst young people these days. I think one of the things that has been good from a public health perspective, and perhaps why the overall opioid death rate has gone down, is that the word is out on fentanyl. People are afraid of fentanyl to a certain extent, and youth have understood that that is a dangerous, scary, lethal substance. Unfortunately, there seems to be a perception of some safety around this medical grade or pharmaceutical quality opioid being Dilaudid or Dillies, um, that has allowed it to take this step towards the mainstream. And to me, it's incredibly frightening. People, some of the time we're not even getting Dilaudid. They're pressed pills that might have fentanyl in them, but people can overdose from Dilaudid itself, even if it is pure or pharmaceutical. As I do air quotes on the radio, which is a useful thing to do, I'm sure. So to me, that's the big thing. So what we've seen is that there is data that backs up that younger youth are using much more prescription opioids. I'm seeing it. It's the story now, and it represents a real change in what's been going on in our high schools and the risk that our youth are facing.
You wrote in your editorial that the problem runs deeper than the toxic supply. Is that what you were just referring to? This idea that youth who are maybe afraid of fentanyl, you're suggesting, are using things like Dilaudid. Can you explain that idea?
Yeah, so I think that's certainly a part of it. And the toxic drug supply gets a lot of attention, and we keep changing the name of the crisis that we were experiencing. It was the opioid crisis for a period of time, and then it was the overdose crisis, and now it's the toxic drug supply crisis. And we're changing the name of the same phenomenon. And currently, with its current name of the toxic drug supply crisis, or whatever we like to call it these days, I think that really does point the direction at fentanyl and other what we call high potency synthetic opioids. And I think that for our youth, there certainly is a much bigger and different player. And the reality is that one of our solutions, or one of our attempts at a solution for decreasing the amount of fentanyl overdoses, was an introduction of hydromorphone as part of safer supply. And the reality is there has been a negative effect on youth from that policy. That policy has probably been life-saving in certain contexts, and I don't want to throw the baby out with the bathwater, but we do have to recognize that none of the tools we use are particularly surgical instruments. They're all fairly blunt, and we have to be very realistic and very sober about our analysis of how these things work. I love that we're trying things. I love that we're trying to do safer supply. And there are certain communities that it's a really good idea in, and perhaps we modify the way that we're doing it to make it a little bit more safe, truly safe. But the diversion has been a major contributor here. Youth wouldn't be using this medication if there wasn't a supply available of this medication. It's such a basic concept that, but it does bear saying. Like, the reason that people are using more of this medication is because more of it is available. And so I think that it's important to realize that anytime that any physician prescribes opioids, there's a percentage of that supply, in a population basis that is going to be diverted. And by diverted, we mean used by somebody who is not prescribed to, in a way that is non-medical, we'll call it. So I think that's an important part because it is different than just the toxicity of fentanyl. That's part of this, but we don't want to forget about the other factors. And to me, I think another part of it is that youth are facing sort of a confluence of two crises. The crises, pardon me. And so youth have been part of the opioid overdose toxic drug supply crisis the whole time it's existed. They've been on the edge of it in terms of our statistics, and we know that the youth make up an important but small number, less than 10% of emergency room visits for opioid use disorder or overdose that we're seeing. But it's an important fringe. But so youth have been part of that crisis. They're also experiencing their very own mental health crisis that we've talked about in the past too, where we're seeing increased rates of anxiety disorder, increased rates of depression, increased rates of eating disorder, increased rates of suicidality and suicidal behavior. And so our youth is experiencing these two things at the same time. And so it's important to think pretty widely about what these youth are experiencing and how do we help them out of it. Because the solution may not just be getting rid of toxic drug supply. It is, we have to treat their opioid use disorder, and we also have to treat their underlying mental health conditions. And that's sort of a big part of what we're calling for in the article, which is treatment of all kinds. And those are the two big categories. We need direct and accessible treatment for the opioid use disorder, which starts with medication. We have two life-saving medications, two and a half maybe even, that we need to be using and have access to youth. Youth need to have access to. And those are things like methadone, classically, or buprenorphine, which is also known as Suboxone or Sublocade, or a variety of different brand names. And unfortunately, despite us knowing that youth opioid use is going up, what we've seen is that prescriptions for buprenorphine and methadone for youth have been going down during the same time period. This is, it's a wild conflict, and we really need to resolve it, and we really need to be able to explain it even. But um, I don't want to get diverted from that first train of thought, being that we have two arms. We need to treat the opioid use disorder with medication. We need to get them the counseling and support that helps them take things from just abstinence or not using a particularly dangerous substance anymore and having some recovery in their life, and pushing out the need for what those opioids were filling in the first place. And separately, or in the same breath, but in a different, perhaps with a different set of professionals, we also need to be treating their underlying mental health conditions. When I make a diagnosis of substance use disorder in my clinic, I struggle to think of a time where there wasn't another diagnosis that happened at the same time. And it's typically things like generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, major depressive disorder, ADHD, eating disorders of all kinds. And so they all have at least two things going on, and we need to treat them at the same time. And a lot of those things require skilled counseling. And here in Ontario, some of the counseling is not always accessible through our provincially funded systems, and if there are some counselors who we might be able to get, they're not accessible in a timely way. So some families are able to pay for this, and then and some are not. And so ability to pay becomes a barrier to care for youth suffering from potentially life-threatening conditions. And to me, there's a moral imperative here. We can't have that. There cannot be a payment-based obstruction from youth getting the care that might be life-saving and certainly life-changing.
This is People First Radio. I'm Joe Pugh. My guest is Dr. Shawn Kelly. He's a pediatrician in Ottawa. He co-authored an editorial in the Canadian Medical Association journal called Canada's Youth Are Part of the Opioid Crisis and Need Treatment. You shared that opioid use disorder is up among youth by some indicators. You've also shared that medications for opioid use disorder, the prescriptions for them are down among youth. Do you have any insight into why that might be?
I wish I had more insight. I think what I have is some degree of conjecture, but I think it's as much as any of us have at this stage. And even if I don't know why we've seen this decrease in prescriptions, I think that I would love to know why. But I think that regardless of why, what we can see is, okay, how do we get ourselves out of this situation where prescriptions are down and use is up? And I think what we need to do is leverage sort of two different groups of people providing healthcare and see if we can get a little bit more care to those people in the middle. And so what that is pediatrics providers. So there's a lot of people out there who see youth, teenagers. And so family doctors, nurse practitioners, pediatricians of all kinds, we see youth. But not too many of my colleagues in that space are comfortable prescribing medications like methadone and buprenorphine. Some of them feel that there's still a special licensing required to prescribe any of these medications, which is not the case in Canada. I don't even know if it ever was the case in Canada. It certainly is the case in the United States that one has to have something called an X waiver. And I think that there's a bit of this cross-border cultural misunderstanding that pediatricians are somehow restricted from this medication. Or, pardon me, pediatric providers more globally. So I include everybody who is making a difference in the lives of kids. And the reality is, these are simple, safe tools that are recommended or evidence-based. We have guidance from the Canadian Pediatric Society and the American Academy of Pediatrics that say these are the first-line medicines here. And I got to tell you, I'm not the smartest pediatrician out here, and I'm pretty good at using these medications. They're easy, but we do need to have some degree of training and some degree of comfort here. And so, what we need to do is expand that comfort zone of the people treating kids to also include treating opioid use disorder. And we also have to, and then we have this pool of adults who are very comfortable treating adults for opioid use disorder. And we have to sort of stretch their capability into giving youth that same treatment, but also perhaps giving them a little bit more of a holistic approach where we're addressing those concurrent underlying disorders. And so, we leverage these two groups and we try to create a nice Venn diagram where there's a nice safe overlap where many more providers can feel comfortable and capable and helpful in addressing this particular crisis in
If
youth.
I am a youth, what is the pathway for me to see a medical professional with some kind of expertise in substance use issues in the first place?
I think it largely depends on where you live. And I think that standardizing this might be a wonderful thing as part of a goal for, what I'd really like to do, this call to arms and create a situation where, or create a much more complete and thorough network of care for youth who need treatment for opioid use disorder. That's the access is a major thing. So if I were a youth and depending on where I was, the sometimes these conditions defy a little bit of insight, unfortunately, and it may not be the youth who's seeking out treatment necessarily. It may be the concern of somebody else. And what we do see is a lot of guidance counselors, teachers, or even drug counselors embedded in schools are identifying youth at risk who are struggling with opioids. And these people need to be connected to treatment. And so, unfortunately, there isn't a direct pipeline often from schools to providers. And so for me, what happens typically is somebody shows up in the emergency room and they'll be, there was a time I was working in the children's hospital and I would go down and meet them in the emergency room. I'm not there at this time. And so typically what they'll do is I'll help the emergency provider start the medication and they'll come to me right after outside. And so there's a pipeline. Unfortunately, it's emergency care where people get it, or sometimes there's other people who will refer somebody into me. And it's almost standard, like, if you want to get a mole checked out and you have to be referred to the dermatologist in order to do that. That's kind of the system that we have right now for addiction medicine care. I'm not completely comfortable with that as the model around here. And so, speaking just as what happens here in my clinic, and this isn't perhaps the ideal, and it's not a recommendation for anybody else to do this, but because of the work that I do, I've become very connected with a lot of the people who work with at-risk youth, be it the Youth Services Bureau, the Child Protective Services, other organizations that work with people at risk or already involved in human trafficking. And so these groups can just call my office and bring somebody. And I don't get a referral and I don't get paid particularly well, and I don't care because the person who needs care gets matched with care. And if they're ready, we're able to make a step in the right direction. So the reality is you have to be lucky to be a youth to get connected to the kind of care that you need at this time. Or you have to be patient and you have to have some kind of primary care provider or a good experience at the ER. And there's a lot too much luck involved in that process right now as it stands. And what we need to have is some kind of, self or family referral situation where people who are at risk or are thinking they might be at risk are much more easily connected to providers with some comfort in the area.
What about the idea of prevention when it comes to youth and opioid use? What do you think could be effective? Are there things we're not doing that you feel that we ought to be doing on a public health front?
Yeah, it's a big challenge. We've long struggled with the best methods for finding, preventative strategies that work very well to get youth to not use substances or not get into trouble with substance use. One of the pillars of prevention is typically education. And the trouble is that most of the time that we do these educational initiatives, there's a bit of a mixed bag. We have a bit of a mixed effect. And for some people, this is a really positive thing that helps. And for others, it's not. And again, it's a blunt instrument. And we don't just direct this at the people it's going to help. We direct it at everybody. And it's you know, uh, I wouldn't say that a particular module added to the school curriculum is going to turn the tide on this in a way that is really important. We have seen changes in patterns of use, though. So we do know that there are some elements of education that are really important. And the understanding that fentanyl is very dangerous, the word is out. And just like from a public health approach, it took from the 1970s to, geez, now. So let's say 45 years of anti-smoking campaigning to drive high school smoking from in the high 40s to way down near 15% of high school students. And so that's a real success story that shows sustained pressure with a variety of different methods that included changing the portrayals of cigarette smoking in movies and things like that, and over a long period of time, patience, money, all of these things to drive it down. There are ways that we can do this that work, but to me, what's really exciting is the Icelandic model. And Iceland 15 years ago was experiencing incredibly high levels of drug and alcohol use amongst their youth. And they sort of said, wow, how do we try to turn this tide around? And they had some mandatory programs that youth were required to participate in to a certain extent that gave them some different options in terms of recreation. That they were sort of there was an obligation of a certain sense to participate in some of these programs, but what it did was have people have different options. And it's often what we talk about here in the clinic. Once we've kind of stopped the bleeding, what we really like to do is we know that things are going well when life is getting bigger and interests are being explored and people have new friends and a new job and a new hobby and all of these, new more things. That's when there's not a lot of room for drug use to happen. And it's specifically opioid use, I suppose. And when people are really sick and their lives are surrounded by opiates, it's a very narrow life. And so I think that looking at our youth and finding ways to get them engaged and having, big, wonderful lives that just don't have room for opioids in them should be the goal around this. How to reach that? I think that we can borrow some of the techniques from the Icelandic model. I think that we also have to look at that other mental health crisis that is going on and give our kids good treatment for these. We have to address the effects of social media. We have to do so many things. And I think the preventative angle is slightly above my pay grade. I am not necessarily a public health professional, but I do think that there's a lot of room for this. And if we have willingness and if we have patience and if we have resources, we can make some dents here. But hopefully this editorial seeks to show that youth treatment here is the bottleneck, and what we have, the crisis that we've been living through of many names is like a wound on our society, a big wound on our society. And there's a lot of blood. And we've been focused on cleaning up the blood and getting better mops. And perhaps that decrease in the daily overdose deaths represent some significant cleaning up of that blood. This editorial is meant to say, why don't we put pressure on the wound and stop the bleeding? And because it's just this choke point where we can make a major change in what this whole thing looks like, 5, 10 years from now, if we put resources, attention, focus, providers, all of this towards this problem at this time. We know that all addiction begins in adolescence. It's almost a developmental disorder in that way. So at that point, where early interventions make a bigger difference, we have an opportunity to bend the twig in the direction the tree will grow. And for me, I see this as a hopeful moment. And we've been dealing with this crisis as a society for so long. The sad thing is, I feel like we're getting to the point where either people's direct experience with the crisis, their indirect experience through family members and loved ones who they've lost or have been hurt so badly by this, even the visual representations of what's happened, to people's cities that used to be robust, vibrant places are now frightening. Open air drug markets, a lot of different things, and I feel like there's been a bit of a hardening of hearts here, And what I'd like to see is that's not who we are, as Canadians, as I hope. And what we can do is take this moment and say, do we want to get hard to this? Do we want to be cold? Or do we want to think widely and see this as an opportunity and a hopeful moment where if we direct our resources in one place, we can change what this looks like? And I think, I really hope that there has been some momentum in that way.
You're listening to People First Radio. My guest is Dr. Shawn Kelly, a pediatrician in Ottawa. In an editorial appearing in the Canadian Medical Association Journal, he called for a more comprehensive strategy to address youth opioid use. That's the issue we've been discussing so far on today's program. So you suggest there that the big impetus for you is you feel that there's this bottleneck, there's this idea that more youth than before are using opioids, that more youth than before are coming to these situations where they are in some way seeking treatment for opioids, whether that's because they have come to the emergency room or are looking through other channels. But the problem is that relative to maybe the adult population, it is even harder for them to get in access with someone who is going to be able to do what we collectively can do for people experiencing substance use issues.
Absolutely. I mean, what I think is that, I wouldn't say that we're doing too much treatment for adults. And I want to reflect that, adult treatment in this space is also under-resourced, but youth are wildly under-resourced and the access is much more difficult. And what we're seeing now is a pretty terrifying wave of what's to come. With the increased use that's happening and the decreased access to treatment, these two things, they add up to a worsening of the situation that we are all, haunted by or so disturbed by as a society. And so to me, if we don't act, this is going to get worse. And if we do act, we can definitely turn the tide on this and make it a lot better. And so, it's one of those things where, if in 5 years, my child asks me, and I know which one will ask me because she asks me the big tough questions. Dad, you've been doing this for decades. Why are there still so many young people out there with opioid use disorder, or, using drugs, or whatever she would say? She probably wouldn't phrase it just like that. But the only honest answer that we'll be able to give, or I'll be able to give, is because we didn't do enough, and because we didn't seize the moment in 2025 when we had it, and we decided to let this happen. And so, that's where I see us right now. We are at a moment where some decisiveness and just we all take a deep breath and we say, okay, we're all tired, but how do we, do we just want to get tired and do we want to stop trying? Or do we want to redouble our efforts? Do we want to call a timeout and put our best line on and see if we can score the goal? And I think that's what the opportunity we have. And I'm hoping that that's what we can do. And that's what we decide to do. And the reality is it will be a decision. This is not inevitable. But it is predictable. And so I think, to me, that's the moment that we're in, is this moment where we could potentially change the course in a major, major way and really correct the problem that's affecting us all.
You've talked about some of the different ways kind of over the course of this conversation that providers can provide treatment to youth. You've talked about, for example, things like medications like methadone. You've talked about the idea of maybe counseling for something that is going on and maybe driving substance use. People also talk about, when they talk about addiction treatment, things like residential treatment, in treatment. There's a lot of kind of controversy around the different models and the fact that a lot of that stuff is private and very hard to access no matter who you are. And maybe just very directly and specifically, what are the things you think we need to do differently? And when you say, like, this is a moment for us to really focus and apply pressure to the wound, what are all of the things you think we need to do that?
Okay. So what I would say is, if we look at treatment options, we can think of it as a pyramid. Okay. And so the bottom of the pyramid, the wide side where most people have their needs, is outpatient providers. It's people, like me, who work in an office, see addiction medicine, look at the underlying concerns, connect people with counseling. So the counselors and outpatient providers and all of that exist on this tier, the bottom tier of the community-based tier, we'll call it, of the treatment pyramid. And this is where most people who with substance use disorder require their treatment for the most part. There are some levels above that in terms of things like a partial hospitalization program or an intensive outpatient where they might come to a clinic several days a week. And this isn't residential treatment, but it's quasi-residential, and they might even get some educational opportunities there. And then at the very tip of the pyramid, where a small section of people are things like residential treatment. And so for me, when we have this conversation, the troubling thing is, those beds in residential treatment are what makes news, and it's providers that make a difference. And so for me, what we need to do is really strengthen the network of providers at that bottom tier or the community-based tier. I'm in there, so I don't mind using the word bottom, but that's where most of the work gets done. And so to me, this is the place where we absolutely need to strengthen. So we need to strengthen access to counselors, physicians, any provider who can do medications for opioid use disorder, counseling for opioid use disorder, diagnosis of other mental health conditions, treatment of those mental health conditions. So that's the network that we really need to improve. Yes, it would be lovely to have some other options for those that need it, but that is a minority that unfortunately it's our we're conditioned to think about 28 days at a rehab center as the treatment for addictive disorders. And while that is a part of it, it is a minority. And so, yes, strengthen that too, but focus on the bottom, focus on the network. And then we get into things like involuntary treatment. That's a whole different can of worms. And in my head, there are for some people who are a danger to themselves or others and require a bit of specialized treatment. But it's a very nuanced discussion, and the whole space becomes incredibly polar. People think, well, just letting people do whatever they want or incarcerating them for 90 days. And there's a whole bunch of subtle things in the middle. And that's really where the discussion needs to be, is to, if somebody comes in having a seizure from a benzodiazepine withdrawal, I will treat them with benzodiazepines. This might be, in a certain way, that's involuntary treatment. I have treated them for their benzodiazepine use disorder, and I am beginning, that we've started on step 0 or step 1 of a benzodiazepine taper, which is the treatment for benzodiazepine use disorder, without getting their consent. I've also probably saved their life from having a seizure that might last forever and cause them to die. However, there's some nuance there. And so I think that that's the space where the discussion needs to happen. My concern about the polls of this discussion are that we know that any public health measure that is designed without significant intentionality is always going to make it, like historically, this is the case, it will always make existing disparities in healthcare amongst different groups worse. And I'm very much concerned that involuntary treatment is going to not look a lot like me as a old white-haired white man, and it's going to look like people of color, indigenous people. And what we're going to see is sort of the same demographics that we see in the carceral system used in this involuntary treatment system, which worsens the healthcare disparities and is not, without designing a program that is incredibly intentional at that particular point, I wouldn't be able to entertain any sort of discussion in that direction. And so for me, we think about harms, but I've gotten off track a little bit here. And so back to, what do we need to do? We need to make sure that people have access to and payment for all of the services they need in their environment, at their school, in their family context, where they can receive good, effective treatment that is life-saving and life-changing. And that's what we need to do. And, that's what I'm asking for provincial leaders to step up and see this as the opportunity that we have. And it's going to look different in a lot of different places. What might work in Ottawa may be different in Nanaimo. But I think that we need to explore, we need to experiment, we need to fail. And we need to be honest about our efforts and say, this worked really well for this particular population. You should try it out there. Or this idea from Halifax blew our minds and we can't wait to try it in Quebec, or what have you. And so I think we can all share the goals, but the pathway to those goals is going to be very different. And I think that we need to allow for a significant, ingenuity, creativity, based on the region that we're in, to try to get to a wonderful place where, we're sharing incredible ideas, we're sharing successes, we're sharing failures so that we don't duplicate the same failures. And really taking this out of the political realm and seeing it as a moral imperative and seeing it as something that we all need to be doing across the nation to find our way forward. Because there is a way forward. And again, if we don't go forward, the only honest answer that we'll be able to give our youth in 5 years, in 10 years, is it's like this because we didn't try.
Is there anything else you think it's important to bring to the conversation on this today?
Oh, there's probably there's a great many things. I think that I talk about medications for opioid use disorder in a state that they're incredible importance. And there's a lot of discussion around, oh, does that mean you're just going to have a 15-year-old addicted to something else? The reality is the medications that we use for opioid use disorder do create a physical dependency. That's not the same thing as an addiction. I'm dependent on brushing my teeth before I go to bed at night, but it's not a pathologic thing. If I don't brush my teeth, I have to get up and do it. But no one's going to say I'm addicted to brushing my teeth because it's not ruining my life. Yes, these medications are incredibly important and they need to be taken continuously. They can be tapered off in a safe and reasonable way. But we have to get away from the idea of we're just substituting one drug for another, because that is a totally inappropriate way to think about these medications. And you know what? I'm guilty of thinking about these medications in that way 5 years ago. I've lost too many people whose lives could have been saved by starting them on medications for opioid use disorder at the appropriate time. It is time to change our thinking about that. The realities of fentanyl and hydromorphone that we're dealing with mean that these life-saving tools are critical now. And so that's the last thing I'd like to bring.
Dr. Shawn Kelly, thank you so much for taking the time to speak with me today.
Thank you so much for having me, Joe. I really appreciate it.
Dr. Shawn Kelly is a pediatrician in Ottawa. You can find the editorial he co-authored in the Canadian Medical Association Journal. It's online and it's called Canada's Youth Are Part of the Opioid Crisis and Need Treatment.
People First Radio, People First Media, and People First Stories are community media projects of Vancouver Island Mental Health Society and are produced in Nanaimo, British Columbia. The opinions expressed do not necessarily represent the views of Vancouver Island Mental Health Society or its broadcast, podcast, and social media partners.